morning, everybody.
Good morning.
A little closer to this microphone. I've got all of my notes here, my cheat sheet for this meeting with all the things I have to say. It says, call the meeting to order. So we are now in order. And welcome the members of the council, the participants, any visitors we have around the room. And you're all going to get to introduce yourself, but we have some really wonderful new members, Greg Alexander, Peter M.B., Christina Ghoshal, Rahul Gupta, Chip Khan, George Kerwin, Edmondo Robinson, and Yanling Liu. And that's really fast, but they're going to talk about themselves for a minute in just a second. Housekeeping notes, these are very important. Okay. So if you need transportation somewhere to train station or airport, sign up before lunch at the desk so people will be able to organize taxis for you, because it's always a rush and they don't sit outside, they have to be called. All new members, this is really important, you have to meet at the beginning of the lunch break to have your picture taken. And I can tell you this is a good thing. The picture that was taken of me when I joined the NAC, it was probably the best picture ever. You know, it makes me look deceptively young and vital, and so I promise you, you really want them to do that, and then you can request a JPEG, and you can use it on all your publicity. I mean, if I left it up to Harvard, I'd look like a haggard academic, depressed and ready for the end of life. So, okay, so also, if you would like to make a public comment, if anybody in the room wants to make a public comment, at 11:45, please let the registration desk know. The cafeteria is across the hall, and I always tell people that if the Korean noodle guy is there, or rice bowl guy, you definitely want to go to him. But I don't know, it looked...
And it's always sold out, right?
Yeah, well, that's right, last time, well, it was the sushi guy, it was the other guy, it was the sushi ramen guy. And so if you really want the best, you have to run to lunch, and it's really quite good. I was alarmed, I heard the sushi guy might not be there.
Yes, indeed, to break your heart.
Yeah.
No.
Yeah, but there are other good guys there and gals, so definitely. Let's see. All right, now we're going to go in, introduce ourselves, just some rules. You have to press this little light on your microphone to speak, and then when you're not, turn it off so we don't have feedback and idle chatter coming through. And if you want to speak, aside from going around and introducing yourself right now, raise your tent card so I can keep track of who to call on. Before you introduce yourself, I'll say just one brief thing. This is actually a critical meeting. This is not something you were invited to because you're important or because you know a lot. It's because it was thought that you could actually help AHRQ with its future direction. And our friend Gopal here has to go and deal with the stakeholders who fund this agency, many of whom are not familiar with health services research, may not have a complete view of how AHRQ fits in with the future of healthcare, and he needs to have ideas that are compelling. So it's not, try not to say the same old, and just talk for the sake of talking, which I know you won't do, but be bold and even disruptive. I mean, the agency needs to hear thinking that's honest and fresh and potentially catalytic, so that the agency doesn't have to fight the same old tired fight every year about why it exists and why it's relevant, how it's different. You have to help define why it's relevant and why it's different and what it can do for the people of the United States. So I hope that's okay to say. That,
Thank you, sir.
and now why don't we go around, and I don't know what a good icebreaker is. I never come up with a good icebreaker, but one thing that's really been worrying me lately is the trend, which is not evident in this room, for people to go to business meetings or meetings like this without a tie. And I'm looking around, I see a couple of people without a tie, but I see more people with a tie. And I don't think this is a gender-specific issue. I think I would love to hear how everyone feels. No interrupting. No, you'll get your turn. I was going to start with you, and now I'm not. So if you would just, in a very brief thing, say what you think about the idea that men should wear a tie. I have to tell you, some of the most expensive suits I've seen, Canali, custom, bespoke, whatever, are on men whose fabrics drip off them like they would never wrinkle no matter what they did, and they're not wearing a tie. So I really want to know what you think. But also, just if you don't mind, where you work and who you are, but a little bit about yourself. I have to tell you that I've just read Paulo Freire's The Pedagogy of the Oppressed, and I'm reading Frantz Fanon's The Wretched of the Earth. And so beginning to understand who we really are and the perspective we bring is critically important. So if you can encapsulate your complex lived experience in just a very small entry into who you are and where you come from, and what your experience is, that would be really, really helpful, so we can really display some of the diverse thinking that's in the room. So don't worry, I'm not that radical, Gopal. You don't have to kick me off for
this is good. I like that.
my leftist leanings. But these guys really, especially the pedagogy of the oppressed, will already has profoundly influenced how I think about teaching, and I think we're all teaching and learning, so understanding each other is really important. So why don't we start? Do we start with you guys or with the NAC? The NAC.
With the guests
So,
today.
okay, Karen. I know it's a heavy order for them.
Thank you, yes. Hi, good morning, everyone. I'm Karen Amstutz. I'm a pediatrician by training and serve on the NAC as a representative of American Health Insurance Plans. I have a career that includes both working in health systems, working for payers, designing and growing Medicaid, primarily government product managed care, so Medicaid, an interest in building care models for special needs populations. And finally, my current position is assisting Indiana University Health in building a community health program that goes beyond the community benefit sort of perspectives that historically nonprofit hospitals have had. So I'm glad to be here. Oh,
And do you think you define yourself adequately in your job?
no, not necessarily, Donald. So I'm located in Indianapolis, Indiana. Three grown children. So launched the last one just recently. Ties, not typically part of my wardrobe. In fact, that I think there's a little bit of sometimes envy that it's much harder. So many more options to choose from when you're dressing as a woman for business, and so having a set formula with a coat and tie, I think, would actually be an advantage.
Good morning, everyone. I'm a new member of the committee, and I want to satisfy our chairman, and I want to talk about tie first. I'm from Seattle, and Seattle, university is very relaxed atmosphere there, and I don't see faculties, very few wear ties. I married 30 years with my husband. I've never seen him wear a tie. So my attitude is do whatever you feel like. Anyway, again, my name is Yanning Yu. I'm from University of Washington. By training, I'm physical oceanographer. I study ocean circulation, sea ice, and atmosphere and interaction, how they affect the climate change. It's because events happened to my dad, who died of medical error, I have become a patient safety advocate. So my main interest now is to bring patients' perspective into healthcare to improve quality, safety, and transparency, accountability. So over the years, I have been involved in lots of projects. I'm faculty teaching at UW for Team STEP, which I'm a big fan of Team STEP. I also a member on Washington State Medical Board as a public member. I also a member on NQF Patient Safety Committee, State Infection Advisory Committee, so I have a very broad interest trying to bring patients' perspective and into this whole process. So I'm honored to be here, and thank you.
Good morning, everybody. Jerry Penso, President and CEO of AMGA, and I'll start also with the tie question, the critical question of the day. Born and raised in Southern California, but interestingly, I'm a family physician and I practice in San Diego, and also then became a medical director. So going to meetings at the hospital and going to meetings for the physician group, I wore a tie every single day in San Diego. Then I came here to the Washington, D.C. area. I work in an office where we do business casual. I actually had to buy new clothes because I didn't have business casual clothes. I wore basically a coat and tie every single day. I still have it, of course, and in the Washington environment, there's certain meetings that coat and tie or suit are just required. So I'm kind of feel in the middle. I have my coat and tie for usually the DC type of meetings, but mostly every day no tie. It's kind of nice. And even last week we had a barbecue at our office and it was shorts. So it was kind of fun. AMGA is a trade association. We represent medical groups and health systems across the country, prominent groups like Cleveland Clinic, Mayo, UW, Christiana, other groups that are even in this room. And we're here in DC because we're an advocacy organization. We advocate on their behalf with regards to the move to value. But we also do more than that. We do education, quality improvement, and we even have an analytics department where we collect electronic health record data from our medical groups with about 25 million longitudinal lives. And we do analytics in support of helping our groups improve quality and reduce costs. And I think that's about it. Thank you.
Hello, everyone. Tina Hernandez-Boussard from Stanford University. I also am born and raised in California, and coming from California, you know, ties are not a necessity. So, but I don't want to make that decision for others because, again, my wardrobe does not consist of a tie. So I think it's as you feel.
Many men dress for their significant other.
As do women. I guess it would be equivalent to say, do we have to wear heels, right? Because I think for women, you know, can we come in? At Stanford, sometimes we get emails, you know, flip-flops are not okay for this meeting. So maybe we could throw that one on the table. So I'm an associate professor at Stanford University in biomedical data science and biomedical informatics and surgery, PhD by training. A lot of my work has been at the intersection of health services research and informatics. I've done in the past a lot of work thinking about quality measurement and patient safety. And given my sort of overlapping interest, we've been really recently thinking about how do we augment our ways of measuring quality and measuring quality and guideline adherence in the digital age. So how do we leverage electronic healthcare records, other digital data? Also spend a lot of my time focusing on patient-centered outcomes and patient-generated data, and how do we integrate that into thinking about valued care and quality measurement. We don't have a lot of ways to measure how value-based care and patient-centered outcomes are incorporated into clinical decisions and clinical treatments. So that's a big focus of my work. And with that, I will pass it on. You're on.
Good morning, everyone. My name is Rahul Gupta. I'm currently the Senior Vice President, Chief Medical and Health Officer at March Dimes in Crystal City. So go back to the tie question. I think that's it's a we often tend to, I think, in this country, think in a binary way, and I think I agree with most of my colleagues who say, do what you want to do kind of thing. So I think it's up to the individuals because the setting matters, the individual matters, and your choice matters. So it's really a choice question to me. A little bit about myself. I think that one of the most meaningful things that happened in my career was very early on, where I helped launch the first Pulse Polio initiative in New Delhi in 1994, which led subsequently 20 years later to the elimination of the disease in a country of 1.3 billion people. And then in the United States, I'm a practicing internist, have been in academia, and my last position was serving 2 governors in West Virginia as the state health commissioner at a population health level, along with faculty positions. So coming back to March of Dimes has been in some ways quite interesting for me to be able to unknowingly where I was able to help a bit in influencing polio eradication, and I come back to the organization that actually helped fund the vaccine to begin with, and now we're focused on the health of moms and babies. One of the, if not the private funder for prematurity research in the world, as well as impacting the challenge of maternal mortality and morbidity across the country. Thank you.
If you don't mind, just to make a footnote for those who aren't that familiar with the history of the March of Dimes and its predecessor foundation. It really is pivotal in the history of polio and the vaccine. But most people don't know it was really the first major organized charity in the United States. It's just phenomenal in what it did. And when I was growing up, we all had cards we could put dimes in, and some of you are too young probably for that. But the other thing about it was that it was the first foundation or organization to realize that indirect costs were really important. So if you want EL to work or whatever, to work on some aspect of polio, you probably had to cover the electricity and the heat and all that kind of stuff. And before that, you could not be compensated for any of that. So it's I actually teach that, of course. I teach a whole class on this, so it's really great to have you here.
Founded by FDR.
Hello, my name is Edmondo Robinson. I am the Chief Transformation Officer at Christiana Care Health System in Delaware. I'm a third-generation Californian. I just happen to live in Delaware now, so that may lead to my tie issue when we get to that in a second. I'm a practicing internist. I'm a hospitalist, actually, a health services researcher, associate professor at Sidney Kimmel Medical College and at Jefferson University. Teach as well, multiple different areas, clinical as well as health systems. My job as Chief Transformation Officer, and I also am Senior Vice President for Consumerism for the health system, is really to navigate that interface around, you're driving a health system towards what the future is going to look like, the future of care, the future of engagement, the future of managing populations. That interface between innovation and really kind of transformation, right? So the way we define innovation is something new to us with an uncertain outcome. Something new to us with an uncertain outcome. The challenge with innovation is that that outcome could be a failure, which is actually okay, but you have to learn from that. And the difference with transformation is that you take that learning around innovation, around implementation science, and you actually drive that and scale it across an enterprise. Right, so it's really a change management function as opposed to kind of just a generation of innovation function. And so that's my role within the health system. Despite the fact that I spend a lot of time in innovation in kind of spaces that are kind of can be ill-defined, I have very much a structure around what I wear, actually. So, and this has been going on for a while. So I'm a hospitalist, and so I've done overnight shifts and so forth. So I have rules. One, I don't wear scrubs before midnight. Right. So I do not come in scrubs. I don't wear scrubs until after midnight. That's rule number one. For ties, I wear tie every day except weekends and meetings. outside of my home area. So that the reason why I'm not wearing a tie is because I'm not at home and I'm not presenting, and therefore I don't wear a tie. Very structured.
It sounds a little bit like you're rebelling against something, but I don't know what it is.
I'm not sure I can follow that. Chip Khan, I guess I'll start with the tie. One, I'm a tie believer. I think it does make a difference in terms of tone and attitude, ties versus not ties. And third, as fashion statements, ties are really very important for setting off the entire outfit. So I believe that without ties, it's just not the same. For the last 8
wearing a tie, you wouldn't wear suspenders.
Well, I believe in, I think everyone around the table should wear suspenders too, but I can't. That's my own bias, and it hasn't caught on. And also, I wear hats every day, which I think are both a health statement as well as a fashion statement, but that hasn't caught on either. I don't know where to go from there. So I am President and CEO of the Federation of American Hospitals, have been for 18 years. We represent 20% of the hospitals, the investor-owned hospitals across the country. This is a especially great honor for me to sit here today because in a sense for me, in a small way, it comes full circle. I spent many years earlier in my life working on the Hill, and back in 1989, one of the things that I did with another fellow called Peter Bedetti, who some of you may know, was draft the original authorization language for the agency that you're sitting here, sitting on the council today. And we had a different name then. There was a rename. And there were bumps in the road since then. And I could tell some war stories about those bumps, particularly in about 1995, but I won't bore you with all that. But the agency's always meant a lot to me, and it's a great honor to actually sit here today, having been there at the very beginning. Second, just in turn, obviously at the Federation, we worry a lot about financing and healthcare delivery in hospitals. One of my concentrations over the last many years has been quality and performance measurement. I've been very engaged at National Quality Forum on the board at one point, and currently sit as co-chair of the coordinating committee of the Measures Application Partnership, and so very engaged in quality measurement at NQF, and also work very hard in support of NQF. So I guess that's one of my other reasons for being here, is that one of the main missions of the agency is very important to me personally, as well as in my day job too. So with that, I'm here.
Just ask Gopal, is it okay? I think the team building is important, but I know we have an agenda. So I accelerate a little bit?
If you want to, otherwise this is good. I
Yeah,
like it.
good.
I think we'll accelerate our work.
Okay.
Boom.
Is it on? Is it on? It's on. Okay. Hi, my name's Barbara Fain. All right, I'm going to dispense with the tie issue early on too. So I frankly don't have a strong opinion about ties, but I am married to someone who does, and who probably shares your view that the tie makes the outfit. I find he has a very large collection, and I will find him standing there every evening gazing at his collection and picking just the right one that he will build his outfit around. His other thing, I don't know how you feel about this, Don, is he's, as much as he's into ties, he does not like suits. He's a sports jacket kind of guy at any occasion. So I don't know what to make of this, but that's my tie. That's my tie story. I am the executive director of the Betsy Lehman Center for Patient Safety, which is the Massachusetts state government patient safety agency. We're a non-regulatory agency. We do our role is around research and analysis. We convene expert panels, and we have a number of activities very central to our work, which seek to engage the patient voice in safety, and we actually engage patient representatives pretty much in everything we do, all of our research projects and our expert panels where they are full-fledged experts because patients are the experts in their care. So I don't know, I'll share one factoid about me since Don, you were interested in sort of what our backgrounds and what drives us, and I without going into a lot of analysis. So I'm a lawyer by training. I got my start actually here in DC at the Public Defender's Service in the mental health division way back in the days when St. Elizabeth's Hospital was a very large federal mental institution, and so that experience, I think, probably in many ways shapes a lot of my thinking about a lot of what I do. So, with that, over to you.
Hi, I'm Greg Alexander, and I have a lot of ties. I just decided not to wear one today. So, and I feel good about that decision. I was sponsored by the American Academy of Nursing and for this opportunity. And I'm a researcher and associate dean of research at the University of Missouri. I've had AHRQ funding for a long time. I've been a KO8 awardee and had a couple of R1s by AHRQ. I lead a CMS study that's an innovation study that's testing new payment models for avoidable hospitalizations, utilizing APRNs and focused on health information exchange and safety and communication. And then I have another study that's looking at IT maturity in long-term care and nursing homes specifically, and have built a staging model around IT maturity and trying to create linkages between quality measures and safety measures that are reported by long-term care to those quality measures. I'm a nurse by training, and I was always told early on in my career that technology would really make a difference in helping me make decisions. It would put me at the bedside. It would do all of these things. And in some cases it did, and in other cases it didn't. And so I've always sort of had a mission to try to understand exactly how IT does make a difference in the lives of a clinician. And so, so I'm honored to be here, and thank you.
Good morning. I'll start with the tie. My husband is a professor, and for 30 years he wore a tie to work every day. And I've always traveled for a living, and I came home one Thursday, and I said, "Oh, you didn't go into school today?" Because he had on a flannel shirt and tennis shoes. And he said, "Oh, yeah, I did. I thought I'd change my image." And I said, "I think you need to find a happy medium or go back to the original image." So that's a nice segue of who I am. My name is Beth Doherty, and I'm from Sparrow Health System out of Lansing, Michigan, and I'm at their critical access hospital at Sparrow Clinton Hospital in St. John's, Michigan. I have worked for the largest for-profit healthcare and I've worked for the largest not-for-profit healthcare system in the nation. I've traveled nationally throughout my career, and I am currently at a critical access hospital. I serve on the Michigan Health and Hospital Association for Rural Health Care, and the Michigan Quality for Critical Access Hospitals in Michigan, which is one of the leaders for quality in critical access hospitals, approached me to ask me to serve on this board. I am trying to make sure that we have inclusion for people in rural areas. We raised our family in an area where the children all graduated in classes under 100, so it's a very small farming community, and our primary hospital is a critical access hospital. So rural is important to me and to our families across the nation who have rural health care.
Morning, I'm Peter Emby. I have a tie problem. I still have ties from high school. I just can't get rid of them. I accumulate them. I prefer to buy them secondhand. You find some really great ties that way. I first learned to tie what I tie every morning, which is a half Windsor. at the Christopher Columbus Catholic High School for Boys in Miami, Florida, where I grew up. Brother Kevin, a Marist brother, did not allow us to continue with Algebra 2 until we could all tie a proper half Windsor. And I would strongly recommend against a full Windsor. It'll just strangle you to death. You don't want to do that. But a half Windsor is nice. Even on casual Fridays, I wear a tie, and I have to get away from that. But it's something I'm working on, and I figure at some point I'll get there. No, but it's seriously a little bit about me. I am the president and CEO of the Regenstrief Institute, which is an applied research institute in Indianapolis. We're actually celebrating our 50th anniversary this year. Health services research, informatics research, and aging research are our main areas of focus, increasingly implementation science. In addition to that, I'm an associate dean and professor at the IU School of Medicine, and I'm the vice president for learning health systems at IU Health, where we're working to actually operationalize the concept of learning health systems. I'm an MD rheumatologist clinically, although these days I mostly do research and administration. I'm also currently the elected leader and chair of the board of directors for the American Medical Informatics Association. And my research is largely in the area of informatics, electronic health records, and how we leverage those for improving research and care. And then a little bit personally, beyond the tie problem, I'm originally from Florida. I'm actually first generation. My parents are Cuban, grew up in Miami, and I'm a proud Cuban American. I also am a sort of lucky victim of the misdiagnosis problem that I know is a priority for AHRQ. I was telling some people at dinner last night, I diagnosed myself with a very rare condition and thankfully got through it and survived it. I had a pheochromocytoma a year and a half ago that was removed. For those who don't know what that is, I can explain it during a break. And I wouldn't be surprised because there's only about 1,000 cases in the US per year. So it's a tough thing to find. But it's the kind of thing that doesn't need to happen, that kind of misdiagnosis. And I'm here I'm here in spite of our health system, which is what we need to fix. So very motivated, even more so than I was before, to help with that, and honored to be here. Thank you.
So I'm Kathy Bradley, and I'm going to circle back to the tie question. And so I'll do the more boring things up front. I'm the Associate Dean for Research at the University of Colorado in Denver and in the School of Public Health. I am also the Deputy Director of our Cancer Center, an NCI designated comprehensive cancer center, where I oversee research programs there. An economist by training. I serve on the National Academy of Medicine National Cancer Policy Forum as well. My area of research has been along two streams. One where merging different data sets, cancer registries with claims data and medical EHRs in order to understand disparities and what's going on with treatment, who got treatment and who didn't and why, and try to disentangle that. And the other line of research has been along the employment outcomes, the effect that treatment, cancer treatment in particular, what do we do when we diagnose early, treat aggressively, but take someone out of the workforce? And try to understand that impact on lives beyond just the treatment episode. And then to move around to the tie issue, I'm a Virginia native, so grew up in a very structured kind of life, very formal. Father was very, very formal, but wore a clip-on. So I don't really know what to say about that, other than he couldn't stand to have something around his neck. And so he had a clip-on. And then now I'm in Denver, which is, sets a new bar, really, for a casual kind of place. And my partner there is a Denver native, has to wear fairly expensive suits but in his job, but in his mind, the tie is a place to be creative. But he also thinks socks is a place to be creative. So he puts together, and he's an accountant, let me just add that. So managed to put together an expensive suit with a ridiculous tie with equally ridiculous socks. And I think the effect gets lost. So I'm kind of leaning toward the clip-on. Anyway, so there you go.
Thank you. Hi, everybody. I'm George Kerwin. A couple things about ties. I have one on. And this hasn't been mentioned, and I'm kind of surprised that it hasn't been mentioned, but from my perspective, Christmas, birthdays, recognition would not exist if there weren't ties, and every one of my ties comes to me through gifting. And so when I put on this tie, I know that it came from a specific person, the specific year, and they have meaning from that standpoint. So that's important. Of course, when you get gifts, they come of different quality. And I've known different quality ties, and those of you who wear ties know that Hermes makes the best tie. It's just incredible, and they're quite expensive. And they typically, if you get one as a gift, you hang it up and just keep it there. Well, my first Hermes tie, and I don't have that many of them because I don't have that many people that give me those types of gifts. I decided I was going to wear that thing. And one of my proudest possessions is an Hermes tie, and this actually does happen, that's worn out. It's totally worn out. Anyway, so that's my life with ties. I'm George Kerwin, and I am from the Upper Midwest, along with a few other members of NAC, and that's an interesting place to be in the delivery of healthcare services. We probably, at times, will get into that characteristic of the Upper Midwest. But I'm a business person by background, undergraduate and graduate degrees in business, and a lot of experience in healthcare. I decided to try to join a health system at a young age, right out of undergraduate, with a business degree, because at the time there were not a lot of business applications within the delivery of healthcare. It was a very clinically oriented type of offering to people, not a lot of business practices. And yet it was a business, as I studied business, like most others, with people and systems and processes and finances and the need to communicate with customers. We had customers. We didn't want to talk about it at the time, but we did have customers. And so I got in at an early age and just have had an incredible career in applying those concepts to the delivery of healthcare services. And of course, today we all know that healthcare services are very, very much dependent on those, in a sense, kind of business practices that we all experience. So that's been a great part of my background that I hope I can share with you. One other point about that issue is I'm identified here as retired. I would have preferred would have said recently retired, because retired is in the past, and recently retired indicates that that person has quite a bit of experience over a long period of time. And when I was in the process of retiring, I was asked many times, well, what's your proudest accomplishment in your career here? And it was very clear to me what that was. My proudest accomplishment was being at the organization long enough to be able to put together the components in a health delivery system that function well, the human components, including the entire medical staff, the technical components, clinical technology as well as information technology, the use of information, the interaction that we have with the market that we're in, with the people that we're serving, to put together the components to be able to say, when CMMI came out with the Pioneer offering, that we think we have the components put together to succeed as a member of that Pioneer offering. And we did join that, and we had considerable success. And so that's, to me, is a long period of time of putting together patiently the components that are required to deliver healthcare services to a population. And that experience and that accomplishment is what I probably have most to offer this group. Thank you.
So rather than having our representatives of other agencies go through the same drill, I'm aware that I've pretty much trashed the agenda. But I think I am going to at least tell who you are. So Paul McGann, I think you're here representing CMMI CMS, and Robin Wagner from CDC, and Kathy Plozek from the VA, and Mike Lauer from NIH. So thank you.
Can I say just one word about ties?
Well, yes, you've been itching, I know.
So Barry Collar is, he's an academic hematologist at Rockefeller University. And he's been very interested in translational research and why translational research has been such a challenge in this country. And he points out that basic scientists, early translational scientists, and clinical scientists really do come from different molds. And emblematic of that is how they dress. So he showed, I remember, a slide where he shows a picture of what does a basic scientist look like. So a basic scientist wears a t-shirt and jeans to work, and that's their normal attire. And clinical scientists dress kind of like us. And that's part of the reason why they don't seem to interact as well as they should. So I think that the question that you ask is an interesting one, because in some respects it gets to the heart of how scientists from different spheres do and do not successfully communicate with each other, and in that way enhance the progress of knowledge.
So yes, go ahead, Robin. You have a tie.
I do have a tie observation that nobody has said here, and I'm really surprised. So ties have never been part of my wardrobe, so I want to address my comment to all the tie wearers in the room and any tie wearers anywhere else. I'm far more interested in what you do and what you say than what you wear. And so that's a message for today. So I don't notice your ties. And I don't really care about your ties, but I really do care about what you say and what you do. So let's do something great today.
So I'll say thank you for that. I was actually going to say, as the designated management official here, I send you tons of logistics. I've never included a dress code question, which will now be added. And I want you to know that I was going to say the same thing. We want you to come here if it means, and share your ideas, if it means it's a long day, and so if it means you are more comfortable doing that without a tie, please do that. And if you want to wear a tie, we're fine with that too, but just come here and share your ideas. Thanks.
So it occurs to me that I didn't tell you anything about myself, and so I'm a Chief Scientific Officer Emeritus at Institute for Healthcare Improvement, and I also have appointments at Harvard and Harvard School of Public Health. Emeritus means that you are searching for relevance every day, because people look at you and say, emeritus, well, you know. I am wearing a tie, and it's a squirrel tie. I have 3 ties with squirrels. And I have a standing offer. Anybody who finds an attractive tie with squirrels, buy it, and I will reimburse you. This one is from Jeffrey Horbar, who's the head of the Vermont Oxford Network, who heard this story, and he went out and got me the tie, and he refused to take reimbursement, but I will reimburse. The question is only half trivial and joking. I went to a meeting around Sustainable Development Goals in Rwanda. And there were ministers of health and people representing many African countries. And everybody was wearing a suit and everybody was wearing a tie. And I asked myself, where did that come from? Why are these people wearing a suit and tie? And what does that mean about the post-colonial era? And what does it mean about cultural influence globally? So although it seemed like a fun question in my mind, I'm thinking, why am I doing this? But even more importantly, why has it become a global issue for people? And next time we're going to talk about what happened to nylons, just so we don't have gender specificity. So with that, Gopal Khanna, I am so sorry I've taken all of your time.
Very good.
You can just say, AHRQ has accomplished a lot, the financial picture is what you know with the budget and blah, 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 and then you can say whatever you want, but I know you won't do that, so.
Well, I'll try to be short.
Oh, okay, well, thank you. Oh, the mic.
Well, you already know my colleague over here, Jamie Zimmerman. She's been working very hard to put this program together, as well as with me over here is Lucy Levine, the CFO. So having introduced quickly the AHRQ team here. Maybe, could I take a second to talk about myself a little bit?
You should.
Okay, there you go.
You're an interesting gentleman. I've
Well,
come to learn.
yes, indeed, indeed. As a first-generation immigrant American, it's a great honor and privilege for me to be sitting here today and leading AHRQ. AHRQ is a great agency. I'm an eternal optimist. I'm an idealist. And I believe that time has come where AHRQ can make an exponential impact on how care is delivered in the country. My background and expertise centers at the intersection of industry, government, and entrepreneurship. So I bring to the table the discipline of corporate America, having served 2 presidents and 2 governors. I understand I'm steeped into policy-making processes. And as an entrepreneur, I love rapid cycle, quick-moving approaches to making change and transformation. I'm a transformation guy. So I love being here. Tie, I have not known life without a tie. I've been wearing one since I was in kindergarten. I went to graduate school as a foreign student, and I was wearing a 3-piece suit with a tie. I looked out of place. My father died because of medical error. And that's another reason why I'm excited to be here, because I believe time has come where we need to think about no harm. I believe in it. And this is just the finest job I've ever had, and feel very passionately honored to be serving. Having said that, sir, may I quickly say a few comments about where we are and how we're going to spend the day?
You are in charge.
No, you are the chair.
I know, but I am delegating being in charge to you.
Well, good morning once again, and thank you to all of you, all the National Advisory Council members for joining us today, and to those of you joining us online and in the room. We are leading healthcare experts here around the table with us for a very timely discussion. I also want to give a special thank you to our chair, Dr. Donald Coleman, for all the tremendous work and leadership that he has demonstrated during his tenure. We're excited to have him back for an additional year to serve in this role. Thank you, Dr. Coleman. I also want to recognize—
I have to interrupt you, Gopal.
Yes.
In my class in college, the only way you can fail, which at Harvard is almost impossible, given the grade inflation, is to call me doctor or professor 3 times.
Okay.
So you have got
I've done
one.
it twice.
You've done twice, so you've one more.
Okay. Thank you, Professor. No, oh my God, I did I did that on purpose so I can get the 3 out of the way. Well, I also want to recognize the new members who are joining us today for their first National Advisory Council meeting. This year we have 8 new members, which means 8 new perspectives with new expertise to help inform AHRQ's work and research agenda for the future. I know we have a full day, busy schedule over here, so I'm going to move very fast and ask my associate director here, Ginger McKay-Smith, I believe she's online, who will provide us an update of AHRQ's accomplishments. After that, we will hear from our Chief Financial Officer, Lucy Levine, to provide a budget update. Then around 9 o'clock, where it is 9:20 already done, maybe in 10 minutes.
We know each other, we're a team.
Yeah, we are a team. I will start our discussion on our past accomplishments, where we are today, and what entails and what is before us in the future and our future strategies. Then we will spend the rest of the day drilling down into more detail on one of AHRQ's strategic initiatives focused on advancing person-centered care, living with multiple chronic conditions. I'm looking forward to these discussions. And again, thank you all for joining us, and I will turn it over to Ginger. Ginger, please take it from here.
Good morning. Thank you, Gopal, for handing it over to me. Good morning, Don and the rest of the council. I'm sorry I couldn't be with you in person today, but I'm happy to take advantage of our meeting technology to speak with you by remote. take a few minutes here at the beginning of your meeting to tell you about some of the highlights of our recent work. Over the past several months, AHRQ has continued our mission to improve the lives of patients by helping healthcare systems and professionals provide care that is high quality, safe, and of high value. With this work as our foundation, we are in a position to support the department's specific policy priorities while continuing to strengthen and expand our expertise in health systems research, practice improvement, and data and analytics. This work has led to many significant advancements, and I'd like to highlight just a few representative accomplishments this morning. So, Jamie, if we could move to the next slide. First of all, we want to be clear that supporting the Secretary's priority initiatives is a major focus for AHRQ, and the opioids crisis is one of the most prominent of those initiatives. As the federal research agency responsible for focusing on health care, AHRQ has contributed peer-reviewed research on a wide range of topics that describe and analyze aspects of the opioids crisis from the perspective of the nation's healthcare system. This research comes from the work of our own staff and also from AHRQ-supported grantees. You see here just some examples to demonstrate how broad this work is, ranging from a study on how reformulating opioids into abuse deterrent or extended release forms affects prescription drug abuse, to a study understanding the effects physician networks have on opioid prescribing patterns, to other studies exploring the relationships among race and ethnicity, social determinants, and health attitudes on overall opioid use. Importantly, in addition to describing and understanding the opioids crisis within this country, AHRQ's research efforts also provide instructive context by comparing our experience with that of other highly developed, medically sophisticated nations. This JAMA open source article is an example of that, describing a study that shows how our dentists' prescribing rates vastly exceed that of their British counterparts. Next slide, please. In another example of AHRQ's participation in department priority initiatives, AHRQ's data resources and our analyses of them have been contributing steadily to the secretarial priority to address drug pricing issues. In recent months, we drew on our unique Medical Expenditure Panel Survey, or MEPS database, to offer trends and analyses on factors of the drug pricing program, including these examples highlighted in recent MEPS statistical briefs and findings reports. The figure on this slide comes from one of those data analyses showing that in 2016, people who had at least one outpatient prescription medication spent on average 31% more than in 2009. So also note that the stat brief shows that the brunt of this increase is felt in the total expenditures figures for the over 65 age group. That's the top blue line there compared with the red line, which is the under 65. Also, while the out-of-pocket costs, which are the lower green and purple lines, decreased during this period, in every year, both out-of-pocket and total expenditures were higher for the over 65 age group. Next slide, please. Apart from the secretarial priorities, Director Khanna has spoken with you several times of the importance of our foundational areas of excellence that are how we do what we do. These three areas or competencies are research, practice improvement, and data and analytics. To begin with research, in the overall scope of federal health research, AHRQ's responsibility is health systems research with a focus on understanding and improving care. Here are a few recent examples that highlight the range and scope of our portfolio, such as a recent AHRQ-funded study showing that more than 80% of antibiotics prescribed before dental procedures aren't necessary, and another study that showed that accountable care organizations, or ACOs, are more likely to use home visits to manage complex patients' care successfully than non-ACOs. Also, a study finding that for Medicare heart patients, hospital readmission risks are highest in the 2 days immediately following discharge from a nursing home. Next slide, please. In AHRQ's work in practice improvement, we build resources that health systems and professionals can use to adopt proven healthcare improvement practices. One example is Take Heart, a new cardiac rehabilitation project we just launched in April. This project is an interagency collaboration with CDC designed to help hospitals implement CDC's quality improvement program called the Cardiac Rehab Change Package. Take Heart addresses research showing that although cardiac rehab following certain types of cardiac events can reduce mortality, morbidity, and readmissions, fewer than 1 in 5 of the Americans who could benefit from this each year actually participate. Increasing participation could save tens of thousands of lives and hundreds of thousands of hospitalizations each year. Our Take Heart project is a 3-year national initiative to support hospitals and health systems improve rates of cardiac rehabilitation use. A different kind of resource supporting practice improvement is AHRQ's recently released Network of Patient Safety Databases, or NPSD. This new database allows us to document, analyze, and understand safety risks and harms, as well as strategies to reduce medical error. The NPSD is the first public database on patient safety events. It is a publicly available online resource that captures non-identifiable information on safety events reported by patient safety organizations in AHRQ's congressionally mandated PSO program. AHRQ will use these data to create resource tools for providers and others to learn about patient safety events and how to reduce patient safety risks and harms across healthcare settings nationally. AHRQ will also make analyses of patient safety events available to the public and will submit a report to Congress on effective strategies for reducing medical errors and increasing patient safety. Next slide, please. In our third area of excellence, while we at AHRQ strive to maintain data that are robust and accurate, we are aware that data alone are often not enough, which is why we focus on data and analytics. By adding the analytics to how we think about and work with our data, we emphasize the capacity to use our data to help health decision makers make the best possible policy decisions. Joel Cohen, director of our Center for Financing, Access, and Cost Trends, and co-director of the AHRQ Data Enterprise Initiative, said in a recent blog, "Only through the effective translation and analysis of today's raw numbers will we adequately identify and confront our most pressing healthcare challenges." One of the foundational steps in accomplishing this is to make our different data available in similar ways, supported by similar tools, and through a common portal. We call this our Data Tools Harmonization Project. Over the past year, members of AHRQ's Data Enterprise Initiative have accomplished a comprehensive analysis of our databases and data tools with a special emphasis on the needs and desires of our data users. At this point, the project has completed technical specifications, assessed different commercial off-the-shelf, or COTS, products, and conducted prototype tests. And we will shortly be making the final decisions necessary to implement and launch a new common data portal and tools. These enhanced data analytics capabilities will ensure that federal, state, and local policymakers will have timely and accurate data and useful analyses to make informed healthcare decisions. Next slide, please. Finally, a review of our accomplishments would not be complete without a shout out to our grantees. who are respected and invaluable partners in pursuing our mission. You've heard some of their work featured in a few of my earlier slides addressing AHRQ's broader goals. I also wanted to mention 2 new requests for applications, or RFAs, which we think will help us tap into the creativity and inventiveness of the research field to help advance our mission and priorities. The first of these, the Partners Enabling Diagnostic Excellence RFA, is a $2 million program to use current data and innovative approaches to explore diagnostic patterns and outcomes. This program will also identify the risk and protective factors associated with diagnostic safety and quality, diagnostic errors, and the effect of diagnostic errors on safety, cost, expenditures, and utilization. The other RFA is for a $10 million continuation of our successful Patient Safety Learning Labs program. The Learning Labs are places and networks where transdisciplinary teams can identify closely related threats to diagnostic or treatment efforts associated with a high burden of harm and cost. The labs provide the environment and resources to devise innovative designs and develop rapid prototyping. They can also put the promising prototypes through further develop, test, revise iterations with the goal of improving diagnosis and treatment. So these are just a few examples in a review of our recent work. I hope they have provided an opportunity for you to get a sense of how we are pursuing our mission and goals. I'll turn you over now to our Chief Financial Officer, Lucy Levine, who will tell you how we pay for this.
Thank you, Ginger. I appreciate it. I am Lucy Levine. I am both the Chief Financial Officer and the Budget Officer, and I'm happy to talk to you a little about the budget, which is my favorite part of my job, especially when it's good. In our current year right now, fiscal year 2019, our budget is $338 million in discretionary funds. This was a $4 million increase over the 2018 level, an $82 million increase over the proposed 2019 President's budget, and importantly, this appropriation maintained AHRQ as a separate agency. The 2019 President's budget had proposed to consolidate AHRQ into the National Institutes of Health as the National Institute for Research on Safety and Quality, lovingly known as NERSC. So that did not happen, and we received a $4 million increase. $2 million of that increase was earmarked to the Patient Safety Program for those diagnostic safety grants that Ginger mentioned. In addition, $2 million was given to the Health Services Research, Data, and Dissemination Portfolio for research on population health. So we are busy working away to spend every single penny of those funds by September 30th. Next, let's talk the sadder news. The fiscal year 2020 President's budget for AHRQ was once again proposed AHRQ to be part of NIH. They only continued within NIH specific programs, a smaller subset. Those include the Patient Safety Program, the Medical Expenditure Panel Survey, the U.S. Preventive Services Task Force at a lower level, the Evidence-Based Practice Centers Program at $750,000, the HCUP program at $9.7 million, $42.9 million in both new and continuing investigator-initiated grants. That is a $10 million decrease from our current level, and $4.5 million in funding for opioid research. So what did they not continue? The Health Information Technology Research Portfolio, including new and continuing grants, were ended. and $38.3 million in contracts related to the Health Services Research, Data, and Dissemination portfolio. That means no quality indicators, no CAPs, both grants and contracts, no data analytics contract support, most importantly, no dissemination and implementation. The population health grants that I talked to you about in the prior slide are gone, and $17.8 million reduction in research management and support, essentially staff related to programs that are ending would be eliminated. So that's the bad news. But the good news is on the following slide. I'm trying to end on a happy note. And we submitted the 2020 President's Budget to Congress in February. The House has given us their mark. It is $358 million. That is $20.2 million over the 19 level. It's our largest proposed increase in more than a decade. The Senate has not yet provided their level. What I can say is I don't expect it to reach the House mark, but it will not be the President's budget level either. And in addition, it's important to note the House does not consolidate AHRQ into NIH. So that's it. I'm happy to answer any questions and to end on a happy note.
So thank you, Ginger and Lucy, and Gopal, having usurped some of the time, we can make up some during what I think is a very generous lunch period. So you really have to rush out to get your noodle bar. But Gopal, could you give us an update and a little bit about your vision for the future, especially I think with this news that the House is supportive. You may want to comment on whether the budget reconciliation that's under, I don't understand all the details, but I understand that it includes an increase in domestic spending as well as military spending, and maybe that's good news too, but you can comment on that maybe.
Now, Don, that's a territory that I want to stay away from, and maybe I'll ask my colleague over there, Boyce, to talk about it. But anyway, may I take a few minutes?
Yeah, please.
Okay. Thank you, Don, so much. And once again, welcome to all of you here to AHRQ. So I'm going to make it quickly, go about this conversation rather quickly and make it short. Well, notwithstanding what AHRQ needs to do today, Secretary Alex Azar has challenged us to think about how we can improve the health and well-being of all Americans in the future. So today we'll engage in a conversation about increasing AHRQ's impact, and with the Secretary's call to action in mind, I would like to share with you my vision for the agency's future. And not only my vision, but also the vision shared by my colleagues at AHRQ, particularly our senior leadership team, who have done a tremendous job in developing strategies to implement this vision. It's one that I hope all of you will inform and embrace as well. Some of the previous NAC members have heard me mention some of these ideas during the last meeting, and I'm hoping to continue to refine these ideas with your help. While there is so much to discuss, the focus of my presentation today will be on three things. First, I will expand on Ginger's remarks and reflect on a few of the great accomplishments AHRQ has made during the first 20 years. Next, I'll talk about where we are right now as an agency and as a healthcare industry as a whole. In doing so, I'll discuss a few of the disruptors that I see changing the nation's healthcare landscape as we know of it today. And finally, I'll share with you what I believe is the future of AHRQ. So my goal is for everyone to feel proud of what AHRQ has already accomplished, confident about the state of our agency today, and excited about the impact we can have on the future of healthcare by preparing for 21st century care for the digital age. With that in mind, I want to start by recognizing a very exciting milestone that AHRQ is celebrating. This year marks the 20th anniversary of the establishment of AHRQ as an independent agency within the Department of Health and Human Services. We are really excited about celebrating this milestone. And indeed, our 20th birthday is an occasion to celebrate, to take a stock of where we are, and to guide our work as we start to envision where we need to be in the future. Over the last 20 years, AHRQ has awarded close to 4,000 grants to over 3,000 principal investigators. Our grants total more than $3 billion. In addition, as you've heard from Lucy, Congress has recognized the impact of our investments and has provided increases in our budget over the last 2 years. Our partnerships with researchers, policymakers, clinicians, patients, and other stakeholders have been vital to our success. Thanks to great collaboration with the entire healthcare community, AHRQ has become the premier funder of health systems research, which has led to substantial improvements in the delivery of care in America. With such great accomplishments under our belt, I want to recognize the super work of AHRQ, both current and former. And by the way, our accomplishments would not have been possible without the agency's previous directors, starting with John Eisenberg, who inspired so much of the work that many of the service researchers do today. Carolyn Clancy, Rick Kroenig, and Andy Beinman all nurtured and extended the legacy that John established. Our investments in research have shown noteworthy impact in safety, quality, and value across healthcare sector. And most notably, AHRQ's funding led to the creation of several major life-saving programs. AHRQ funded Dr. Peter Pronovo's Comprehensive Unit-Based Safety Program, or CUSP, which dramatically reduced fatal bloodstream infections in hospitals and saved thousands of lives and countless dollars. Additional AHRQ funding that then helped expand that program to more than 1,100 ICUs nationwide. In total, national efforts to reduce hospital-acquired infections helped prevent over 20,000 hospital deaths and saved over $7 billion in healthcare costs from 2014 to 2017. Our grants also established and evaluated the first clinic for the Extension for Community Healthcare Outcomes Initiative, known as Project ECHO. This project, led by Dr. Sanjeev Arora at the University of New Mexico School of Medicine, not only helped rural providers combat hepatitis C through telementoring and teleconsultation, but additional AHRQ funding is currently supporting states to use the ECHO model for opioid addiction treatment as well. And if successful, this model will bring medication-assisted treatment to an additional 20,000 Americans in need. And one final example of our success in the last 20 years, AHRQ has been a leader in driving value as well. With our support, Dr. Brian Jack of Boston University Medical Center was able to create the re-engineered discharge toolkit, known more commonly as the RED toolkit. Hospitals that adopted this patient-focused approach to coordinating follow-ups saw a nearly 1/3 reduction in 30-day readmissions. Now, none of this work would be possible without the help and support of the researchers who provide the evidence base to effect real change. I salute them, because their work has improved delivery of care and has saved lives. That is the true success of AHRQ over the last 20 years. However, we are at a crossroads. Everything about healthcare landscape has changed the way it is delivered, paid for, regulated, even talked about. Some of these changes have been gradual, some sudden, but all have been significant. And now, the change is accelerating like never before. I see 6 major disruptors impacting how healthcare will be delivered in the future. And as such, the work of AHRQ and Health Services Research as well. First, I see the aging of the population both in terms of elder care and the change in the way younger Americans consume healthcare services. Next, I see mergers and acquisitions and consolidation changing everything from incentives to care coordination to fundamental ways in which care is delivered. 3, I see the proliferation of network medical devices or Internet of Things. 4, the digitization of everything. Number 5, the volume, variety, and velocity of data, new data moving through our healthcare system. And lastly, we cannot forget this one, new entrants in the delivery space, the Googles and the Amazons and even the startup ventures that are all looking at how they can change the healthcare delivery systems. The speed of change is breathtaking. So what do all these trends mean collectively to us here? Today, as we think about future strategies, with some we can anticipate where they will take us, with others we don't really know. And at this point, we have no idea what the outcomes will be. However, what we do know is that all of these trends are converging to disrupt and reshape the delivery of healthcare. We live in the digital age, and we are witnessing a compelling need for a rapid transformation into 21st century care. Given this reality, we at AHRQ have taken a step back to ask ourselves, what do we need to do to position ourselves for the future? And that has required us looking at AHRQ in a new frame. As this slide shows you, at one end, we have the NIH driving research, an extremely important research agenda, and they do a wonderful job, life-saving work. At CDC, at the quadrant at the bottom, we have research for public health. And at FDA, we have research for drug safety and efficacy. But equally important, ladies and gentlemen, is the work we do at AHRQ, which is research for care. I believe cure and care are two sides of the same coin. While science and research to discover cures is needed, but science, research, and implementation to improve care is imperative. So let me talk about what care means. We really are moving from the brick and mortar era of the 20th century to the digital age of the 21st century. So if you look at the care continuum from prevention to palliative care, what you're looking at is an estimated 275 million Americans pass through that care continuum each year. We spend over $2.5 trillion on the delivery of healthcare services. And within that continuum, there are many unanswered questions, pain points, and unmet needs that must be resolved to ensure safe, high value, high quality, whole person, holistic care for the American people. While we are happy with the progress we have made thus far, we need to do a lot more. And the solutions begin with more health systems research. We need to discover new knowledge and provide needed evidence that optimizes quality, safety, and value of the care that patients receive. Since I began my work as director of AHRQ, I have made it my priority to listen to stakeholders from across the healthcare industry. I have been meeting with patients, researchers, systems leaders, and policymakers, among many others like you. I've heard that in addition to investigator-initiated research, there's a compelling need for rapid cycle research, for operational research, targeted research, transdisciplinary research, applied research, and most importantly, digital health research as well. Yes, learning health systems have to evolve over time. I see that. But I see it from a process improvement perspective. We need process reengineering that improves efficiency and effectiveness of our services. We need to focus on a whole person 360-degree care. Not just worry about the data flowing into the system for the sake of big data, but data that includes social determinants of health and changes that way clinicians practice, driving questions we may not have even thought of yet. This is why AHRQ is focusing on supporting a shift towards learning health systems that discover and evolve, that utilize a process improvement perspective. Now, given all of the disruptors that I've talked about, AHRQ needs to focus on how we can use our core competencies to have the greatest possible impact in the future. With that in mind, here's how we see our role, the why and the what and the how. Our core competencies really are rooted in health systems research, practice improvement, and data and analytics. And our aim is to help healthcare systems professionals deliver care that is high quality, safe, and high value. We have to leverage our core competencies and build upon them. And at the end of the day, our vision and end goal is to improve the lives of patients. This slide basically talks about how we believe we can increase exponentially AHRQ's impact in the future if we work together. What you're seeing is, at the very bottom, our foundational work. That's what the Congress expects us to do, and we must deliver now, today. But at the same time, to position AHRQ for the future, we need to think about where the puck will be. I've talked briefly about the digital age. That's where the puck will be, and we need to position ourselves with that in mind. So to innovate for the future, looking at our core competencies, there are 3 areas that I'll talk about a little bit more as we go along. Multiple chronic conditions, dealing with misdiagnosis, and data and analytics. And to get there, we need to increase our current capacity and build upon it. And at the same time, respond to the secretarial priorities which Ginger just talked about. A few years ago, Congress passed the 21st Century Cures Act to bring us the cures of the 21st century. My belief is that the next frontier is to bring to the American people 21st century care. Think about it. To do this, AHRQ is developing long-term strategies to address 3 critical challenges that are front and center in the evolving digital healthcare ecosystem. Number 1, improving care for Americans living with multiple chronic conditions. 2, providing data and analytics to policymakers to empower informed policymaking process, and reducing diagnostics error. I believe concentrated attention on solving these 3 challenges together with the appropriate resources can have the greatest chance of delivering meaningful impact to Americans. As mentioned, the first of these 3 challenges is improving care for patients with multiple chronic conditions. Think about it. More than 25% of Americans live with multiple chronic conditions. That includes, by the way, 80% of Medicare beneficiaries. The need of people with MCCs do not align with the way care is delivered today. Care for these patients is often fragmented, leading to poor outcomes and increased costs. We all know about that. A multifaceted initiative to catalyze the development of a sustainable system that delivers high-value, coordinated, integrated, whole-person care could radically change the lives of people with MCC. We believe the system should be based on primary care. and by doing so, prevent and manage multiple chronic conditions. AHRQ stands ready today to make this system a reality by leveraging all of our 3 core competencies in health systems research, practice improvement, and data and analytics. I'm looking forward to doing a little bit more of a deep dive later this morning and afternoon, and this work will be led by my colleague, Dr. Arlene Bierman. Are you here? There she is, and she's going to lead that discussion shortly. Well, I believe over a 5-year period, we think AHRQ can set the stage for significantly changing the care of people living with MCCs. In addition to improving health outcomes, quality of life, and patient and family experience with care, if you are able to reduce health expenditures for this population by a mere 0.1%, we will save the nation $2 billion annually. Of course, we won't be able to create this impact alone. We are counting on you to join us on this journey. I hope you will be willing to see yourselves not only as stakeholders, but also as advocates to help us accomplish these important goals. Our second goal is to improve data and analytics capabilities for research, policy analysis, and improvement. Despite the explosion of data, many policymakers today still make decisions based largely on expert opinion alone, rather than data, evidence, or predictive analytics. Just as healthcare has embraced the practice of evidence-based medicine and is moving to create learning health systems, I think we need a parallel transformation in policy-making processes as well. Policymakers lack access to timely data and analytics to make informed policy and operational decisions. We can't get to real-time decision-making informed processes by the best evidence available without an integrated data analytics and information platform to capture more of a holistic 360-degree view of the healthcare system at large. AHRQ is prepared to build on our existing current extensive background and experience and expertise, as well as our existing data infrastructure to add new data from public and private sources to expand our nation's capacity to provide timely answers to critical policy questions. For starters, AHRQ is prepared to develop, enhance, and integrate 4 data resources, expand MEPS, create a national Medicaid data and analytic platform, create a national small area social determinants of health platform, and develop a physician practice and physician organization database. While building each of these data sources has value, we must be sure that these data are integrated, more easily available to researchers and entrepreneurs, and accessible to local, state, and federal policymakers. At the same time, we must also focus on predictive analytics to address rapid cycle requests from HHS, Congress, and states. AHRQ stands ready to make this happen. And finally, our third goal is improving diagnosis. Today, an estimated 12 million people per year are affected by diagnostic error, with approximately 4 million of these people suffering serious harm. Research suggests the cost of diagnostic error to the US healthcare system exceeds $100 billion annually. We think it's possible to prevent 1 million diagnostic errors by the year 2025. And working together, we know that we can put in place the initiatives needed to achieve that goal. But again, doing so will mean using all of our core competencies and bringing our expertise to bear on finding and implementing solutions. Just as with MCC, we need new research on barriers and interventions to improve diagnosis and healthcare. This will include developing and testing digital solutions, including artificial intelligence, and understanding workflow in all its components. To increase the impact of this work, we should focus our initial research on the 3 largest areas of diagnostic errors: cancer, vascular conditions, and infections. It is estimated that these areas account for more than half of all diagnostic errors. While awaiting new research evidence and insights, we must ensure that health systems and professionals understand what is already known about improving diagnostic safety, and we must disseminate the findings through our existing safety networks. This must include large-scale implementation projects to support frontline providers and patients to address the challenges associated with laboratory results follow-up. And just as important, by the way, we must also turn an array of diagnostic data into actual information that patients and clinicians need for making important decisions about care. In the past, AHRQ has successfully used centers of excellence to spur innovation and spread insights and practice improvement models. We should again develop several national diagnostic safety centers of excellence to support development and testing of novel approaches that make better use of data and help make those analytic and data solutions available to stakeholders. We should also find ways to measure and improve patient safety culture and explore development of a diagnostic safety culture survey. Well, in conclusion, I hope you will agree that there is enormous potential for improving healthcare quality, safety, and value by focusing our attention on improving care for Americans living with multiple chronic conditions, providing data and analytics to policymakers to empower informed decision-making, and reducing diagnostic errors. AHRQ has both the potential and a plan to deliver substantial impact in these areas. Today, AHRQ stands at a crossroads. Much like our healthcare system at large, we cannot afford to kick the can down the road and wait for someone else to solve our problems. To me, challenge is synonymous with opportunity. I hope that I have reassured you about AHRQ's place in the healthcare ecosystem. I hope I've challenged you to look ahead and tackle the hard problems, and I hope that you will leave here today recognizing that there is a bigger, better, and bolder work ahead. I'm really excited to hear your feedback about these exciting strategies and initiatives, and look forward to a more in-depth conversation as it relates to MCC. Again, thank you for your time and service to AHRQ. I will now turn it over to Don, who I am confident will do a great job moderating this next part of today's agenda. Thank you so much. I appreciate you being here.
Thank you, Gopal. Just before we continue, I know that Chris joined us and did not get to introduce herself. So Chris, could you just briefly tell us about you?
Very quickly. So I am Chris Goschel. I am a nurse by training with a doctorate in health systems management. I'm one of those people who has always been frustrated by the juxtaposition of clinical care, leadership, and research, and how they just don't seem to come together. Early in my career, I thought I could make that happen by shifting from clinical care to leadership, and I had some success, but not enough. So I got a doctorate and started doing research, and I had some success and not enough. So I jumped back into operations, and I had some success, but not enough. And I recently have shifted back into doing research almost full-time with a focus on improving diagnosis in healthcare. I was fortunate enough to sit on the National Academy of Medicine panel that did the initial work on improving healthcare diagnosis. I'm passionate about that, and I'm leading a center that we've started up at MedStar Health, which is where I'm currently employed. I am probably one of the most, I'll say, greatest advocates for AHRQ. I was the recipient with Peter Pronovost of one of the first Patient Safety Challenge grants issued by AHRQ. And that work led to some of the work that is still being done across the country to reduce central line associated bloodstream infections. But quite honestly, my love affair with AHRQ started then. And I've had a lot of personal funding since then from AHRQ, but I am a voracious user and firm believer in going to AHRQ first for tools. I teach in the School of Public Health at Hopkins still, and the Patient Safety Net website and all the tools that we have is a place where we go, the national strategy. This is where I think the future of healthcare delivery lives and breathes, and so I am honored and excited to be here. And quite honestly, I selfishly am here to learn, but I will contribute whatever I can along the way. I have to tell you a Thai story though, because I jumped in the middle of this, and I thought, how weird. Why are we talking about Thai stories? And then as I heard, so I tend to believe things firmly, and I'm not afraid to approach people that I don't know well if I have ideas. I did that with Peter Pronovost. I mean, challenged him to say, it's great that you could reduce bloodstream infections at Johns Hopkins, but the world doesn't get its healthcare there. Let's see if we can do this in Michigan, which is where I had started the Keystone Center. The Thai story, though, I was having flashbacks as people were talking, takes me back to one of my very first roles as a senior executive in a hospital. And I was at my very first senior leadership retreat, and our CEO had been in place for many years. He was esteemed. He was probably one of the best leaders I've ever seen in my lifetime. And he wore starched white shirts and ties, very formal person. And our senior leader retreat, for the first time ever, said, business casual. And every other man on the senior leader team showed up without a tie. Several had them in their pockets, but they were not wearing ties. And on the first break, it was, he told us to do this, and he's sitting there in a tie. How can this be? And I thought, well, why don't we ask him? Why don't we tell him? And they were like, Mikey, you do it. So I did. And I went up in a safe space and just explained that people thought this was, we were working on leadership development, and it was going to be a new day. And business casual, it was very clear that people didn't really need to wear ties and et cetera. And yet he was wearing a tie, and that confused people. And he turned red, and he said, well, I have a retreat tonight after work. And I said, but you could take your tie off and put it back on. And he was like, oh, I would feel naked. And it's like, but you're the leader. I'm young and naive. And I say, you're the leader. And he said, well, okay. And he took his tie off. And I said, now you have to unbutton. and he did a little, and he went back, and he was flushed, and he was red. He thanked me for saying that, and he made everyone promise not to tell his wife. So everyone has a tie story, I think. Thank you, Don, so much. I am truly, truly, truly honored to be here.
So we're going to push the break, if you don't mind, for about 20 minutes, so we can have at least some dialogue about Gopal's very interesting and inspiring talk. And I hope you've all been taking notes. I did have one clarification question, because it went by, I didn't get it all down. You mentioned 3 data platforms that you were interested in. One was about social determinants, another was, I think, Medicaid, and then there's a third that I didn't capture. That's so important. What are those 3?
Social determinants?
Yes.
That was the third one, and the fourth one was MEPS expansion.
Okay, so let's go over all of them, because I think it's really, really key. What are the 4?
I'm going to call upon
I think
Joey.
the one you're talking about had to do with enhancing our provider data resources.
Okay.
And we've started on some of this.
Do you want to go to a mic?
Thank you. So we started on some of this with the MEPS. We got actually funding from the Robert Wood Johnson Foundation to add what we call the Medical Organization Survey to the MEPS. So we went back to the providers of care, to the people who are participating in the medical expenditure survey, to ask them about characteristics of the providers that they saw. So we actually went to the physicians' offices and asked them about what their organization is, how many docs there are there, who owns the practice, how the physicians are paid, et cetera. So a set of information so that we could look at the characteristics of providers and how that has an impact on the care that's delivered. So this is an area in the federal data resources that's really lacking these days. There are no good provider surveys, have information, and particularly the linkage to the individuals who are using the services and what their characteristics are and what they're using, et cetera. So our proposal proposal is to enhance those resources and expand that, again, building off what we did in our medical organization survey.
While I ask this next question of you, if people could start putting up their tents. To put up your tents so you're ready. But, and then the social determinants, is this different than county health rankings or other surveys? What is that going
Yeah,
to be?
we have a couple of projects. I mean, this is an area that's, people have talked about a lot lately, with a recognition that a lot of health outcomes are not determined by medical care, but by individuals' characteristics and their environment and their past experiences, et cetera. So we have a couple of projects here. One is sort of an internal one where we're trying to put together from available data information on different social determinants, and then linking that to the information that we have now, like the Healthcare Cost and Utilization Project or the MEPS survey, et cetera, and also creating a database with a geographical linkage so people would be able to link these data to other data sets if they wanted to. Then we have a very large project with PCORI to develop a larger database that would be then available again publicly for people to link to whatever databases that they have. So that's a multi-year project that we're just getting underway at right now.
Okay, and just a fair warning, obviously this can be either a virtuous cycle or a destructive cycle in which we have great ideas and plans and the money's not forthcoming, but if we're inspiring and visionary and it can describe exactly what it is we want to do, it could be the funding will flow, so hopefully.
Absolutely.
But that's a critical thing for us to keep in mind. There is no accomplishment of a vision without some support. So I'm sure you know that far better than I. For the parking lot, Gopal, we'll come back to this maybe. I love that four-part, this is the FDA, this is CARE. That actually was the clearest exposition, if you will, of what's unique about AHRQ. I've seen a lot of mealy-mouthed, detailed things. That was really, really clear. But on the parking lot, if we could come back perhaps to where the VA fits in, where much of America's research and training is performed, where CMMI fits in, which spends hundreds of millions of dollars on programs that it tries to evaluate, and where the data analytics and data platforms of the CDC fit in, all of this, and where the NIH D&I portfolio fits in. So these are, in a way, one could say all of that belongs in AHRQ. And maybe it does if it's around the care piece. So if we could begin to think that through and come back to it in our afternoon session when we're focusing on the high-need population, that would be great. So let's take, why don't we, I think you were first, Peter. Why don't you go ahead?
Thank you. There's so much to unpack, and I will just say at the highest level, I think it's very clear that your strategy that you've laid out is very well informed and inspiring, and I think you are on the right track. I think the things you've identified are burning platforms, are critically important. So I just want to endorse a lot of what you said because I think you're on the right track, and we've talked a bit about it. I want to pick on just one of the things you mentioned, and we were just talking about, which is the social determinant space. So there's a lot of work, as was pointed out, happening in this space. And yet, the way we think about this, and I think the way a lot of people are thinking about this increasingly, is we're kind of at a place now with social determinants where we were with clinical data maybe 30, 40 years ago, where there's still a lot of foundational work that needs to happen in the area of sort of standards and how it is we're actually going to traffic in these data, what meaning do they have. They are obviously at varying levels of granularity in terms of their connection to individuals and trafficking, and that is not at all easy. While we see a lot of investment happening at the level of agencies, at the level of states with departments of health and Medicaid agencies, health systems, certainly looking at vendors, trying to figure out how they're going to manage and integrate these different platforms that traffic in social determinants, et cetera. there is very little, if any, evidence to base any of these decisions on in terms of what should we be doing, how should we be doing it, what should we be purchasing, how do we go about deploying these and using them for the intended effect. So it's a great opportunity, and I think squarely in the realm and scope of what AHRQ can and should be funding, to be thinking about some of the science that needs to be done to really inform, for instance, what should we do in the realm of standards? How do we traffic in this information? Even in the creation of a resource, and I applaud you for thinking about creating such a resource, that will be one of many such resources. States are developing them, again, individual academic health centers are developing them, and we are likely to all go off in different directions and create them in different ways that can't communicate with one another, and we're going to be sitting here 5-10 years from now saying, gosh, how do we reconcile this? How do we figure this out? I think now is a great time, anticipating the need for this, to say, let's try to put some rationality around that. And as a convener, as a leader in the care space, I think AHRQ is in a great position to try to formulate some strategy around how we should be approaching this intersection of phenotypic information and exposomic or social information for the purposes of improving the health system. I think there's a research agenda to be fleshed out.
Somebody else had a tent card up and it disappeared. Do you want to put it back up? What were you going to say?
So I'll add to that, and I do have a comment about one more issue, which is social determinants. I think in the absence of this, what's happening is insurers and payers are feeding the social need instead of addressing the social determinants. So it's almost become a need issue. So let's provide you, for example, Uber rides or Lyft rides, or rather than actually addressing the fundamental challenges on the ground, like homelessness and transportation deserts and maternity care deserts, those types of things. So I think there's a lot of value in developing foundational framework that actually addresses not just downstream but upstream the issues of the social determinants of health. I was going to mention a little bit yesterday. So I think one of the issues also is to link some of the great work that happens with the MEPS data to also look at contextualizing in terms of policymaking. There's a lot of debate, for example, about the association plans or skinny plans, and so perhaps some of the data to the effectiveness of these plans. So insurers and as well as some of this thinking about how do we get ahead in our policy debate by getting the data that's needed at the ground level, so we're helping inform good policy in terms of in terms of coverage and other things as well. So it would help us to know, because access obviously is critical to good health care. Not the only solution, but it's very critical. Thank you.
Thank you, Chair. This is a great presentation. For being a new member, helped me really understand the vision and the things AHRQ needs to be doing. One of my questions is that, you talk about fundamental work, which is practice improvement, but I don't know what is agency's thoughts and what's the vision on that, because there's a budget cut in quality indicators, works on quality indicators and dissemination information contract. I just wondering, talk about improve the practice, but without measuring, without know how we're doing, how to implement, how to get indicators of the qualities. And it seems that there's a missing link. I don't know if the budget would help to get some of this, but in a remedy, what would be a way to engage other stakeholders, state or other, national quality measure organizations to fill the gap, to connect the link, to really continue the quality measures. And, I felt that's very important. to know how we're doing. Otherwise, we don't know whether we have a greater research grant, we have, a lot of good results, we analyze the data, and we try to implement it. And then we don't know what's the results of the implementations, how do we improve the care. So I felt that's this whole issues about improve the care, the quality, safety. So I'm just have some.
Well said, and I appreciate that because I think there are 2-3 things that you're saying, and one of the things that really stood out was stakeholder engagement, and I'm hoping that today we'll talk more about how AHRQ alone cannot do everything. We know that, so we'll have to have strong partnerships and get stakeholders involved. At this point, what I'm doing is laying out a long-term vision and a plan, and I recognize these are multi-year efforts and they're going to build upon them. So your point is well taken, and we need to take stakeholder engagement particularly into consideration. Thank you.
Chris, please.
Very quick comment. I think, excuse me, I think of the, thank you. I think in terms of the vision, kind of tying into what you suggested, Don, about perhaps missing, I'm curious whether it's a marketing initiative or those of us who advocate, but reaching out to community partners that we've started to work with based on AHRQ's agenda setting and some of the research that we're doing. And what I'm finding is many community partners don't know where to go for information or resources. And I think there's a ton of information at AHRQ. So some of the work that's being done on culture, creating a culture of health, and people will contact me and say, I don't know how to engage with hospitals or health systems. Where and how is the agenda for hospitals and health systems being sent? So I just think in that future vision, idealizing that perhaps AHRQ's primary stakeholders are not just hospitals, health systems, and providers, but really other community agencies that are involved in partnering with their local hospitals and health systems.
Well said. And point well taken. We need to think more broadly than just the way we are right now.
Great.
Thank you. I wrote down 4 topics, and this was sort of in relationship to your idea around the 360-degree view of the healthcare system. So I came from acute care in my beginning years in ICU and med-surg and lots of acute care experience. But I transitioned out to community and home health and long-term care, assisted living settings, where I think there's a huge shift and focus now. And so I think that in relationship to your idea about 360-degree view, that I apply to AHRQ because you have a current call out for grants. I think it's an R18 that has to do with long-term post-acute care, quality, and those types of things. Long-term care is oftentimes overlooked, I think. There was a big gap that was created by meaningful use that occurred because we stopped at the acute care and ambulatory care setting. We didn't take it out into the long-term post-acute care environment, and there's such a need for innovation, and there's such a need for enhancing advanced practice and raising the level of the ability of nurses to practice at their proper level. And so, and I think those all impact quality. And so I think that, along with just rural settings and long-term post-acute care in rural settings where people are trying to stay in their home and they're trying to age in place, are important areas that provide a unique point of view around that 360-degree healthcare point of view. And I think AHRQ is really uniquely positioned to understand the relationship between quality improvement in those areas.
You still have your 10th up. You another comment, but we'll go to Kathy first.
Yeah. Just an observation that I think on a lot of these data platforms, what's often missing is what's going on within a state and how they implemented major policies. So we think about social determinants of health, which is incredibly important, but if you put that in the context of how did that state implement Medicaid expansion? And to have some sort of companion on whether they look at different levels of expanding insurance, of different levels of threshold, people that are reached, people that are covered. This kind of information is often missing from our data sets of what interventions work, what policies work, how different states approach different problems, to be integrated, to understand the environment and the support systems that are there that influence how systems are structured, what's reimbursed, what isn't, who's covered, who's not, and then how that ultimately influences health outcomes within an area.
Thank you. Point well taken. Unless one of my colleagues want to have any additional comments on this issue of social determinants, Mamta, Joel?
I would just say that that's one of the reasons we're proposing to expand the sample in the MEPS, because right now, we're limited in what kind of state estimates we can make. And you can think of ways to try to do studies that, where you don't need, where you can group states and that kind of thing, but you don't get the kind of detail that you're talking about. So this is exactly why we're proposing to expand those resources, expand the sample size in the MEPS. We have some plans to talk to individual states about, getting together more detailed information from a set of states, something on along the lines of what we do for HCUP, where you would, collect information that the states put together. And there are a few states out there that actually have a lot of information and do put it together at an individual level across the state, across different programs, and you can look at that. So we're exploring ways to expand that, but that's exactly the kind of thing that you're talking about. I think you're absolutely right. You need that level of detail in order to understand what's going on and what the impacts of policies are going to be.
Yeah, and I just want to give a little bit more information. Lucy mentioned that we were very excited. We got $2 million from Congress this year to look at population health. And what we've done with that, we issued a funding announcement where we asked people to figure out how to combine clinical data on community services and social determinants of health data in a way that they could share it with primary care practices and use it to manage both high-risk patients and high-risk communities, and also to do more partnerships. We encouraged in their partnerships with community organizations and public health. We actually got 50 applications. We got some really innovative action. We had the study section met a week ago, and we have really some real innovative applications to that. So I'm really, really excited. And then just to go back on kind of the standardization, what do you measure, how do you measure it? We have another project internally funded through ASPE, through the PCOR Trust Fund, to develop interoperable electronic care plans to be able to do patient-centered care in the community. And part of that is incorporating social determinants of health data and trying to build on the work that other people are doing and try to come up with some consensus on standards that you could use for that purpose. So just wanted to add that.
Thank you, Joel and Arlene. Thank you.
We'll come back to it, but Karen, could you comment?
Sure, thank you. I think that another issue that working with social determinants data is going to raise concerns the community organizations that will be partners, and there's going to need to be capacity building within those community organizations in order for them to leverage and use the kinds of platforms and technology that we're talking about. But furthermore, it's going to raise a set of questions around standards. Things, if you think about credentialing providers, if I'm a healthcare organization and I'm referring to a community organization, do I now have an obligation to do more due diligence or some type of credentialing process? So it raises a whole a set of issues related to the standards around community organizations. And of course, I think all of you can anticipate the downstream implications that might have for the sort of organizations that may have fewer resources.
I'm saying, I'm putting on mic to say Jerry, so people on the phone will know who's speaking.
Excellent. Thank you. Gopal, first of all, thank you for your inspiring vision. And I think our medical groups and health systems would wholeheartedly agree with those priorities. Two things that I just wanted, that I heard in your disruptors that I live every single day, and that's the issue of mergers and consolidations and new entrants into the health space. I was very pleased to hear about the medical organization survey and just a few data points, because what we believe at AMG is that the delivery system matters, so that the context for practice improvement, or the context, the organization for data analysis, we think actually is an important component that needs to be very well studied as part of the overall context. 10 years ago, my members, 2/3 were standalone independent medical groups owned by physicians. Now 80% are either owned or affiliated with a hospital or for-profit entity. So that's a dramatic shift in the entire marketplace. I open up the newspaper or the internet every day to find out which of my members has bought another member. So we're finding very much that the whole healthcare system and the ecosystem has changed dramatically. The amount of private equity that's entering the marketplace is huge, buying practices at an unprecedented rate. And we think that's going to have a dramatic impact on how healthcare is delivered in this country. And I think, again, I would ask you to keep an eye on that, help inform healthcare policymakers, as well as those of us who are working in quality improvement, what the impact is of that, either positive or negative, as a factor.
Thank you, Jerry.
Let's go to Tina and then Peter, and then I'll wrap it up so we can get to break, because I think people are getting a little nudgy here.
So I want to follow up on some of my colleagues' comments regarding social determinants of health, and in particular Karen's comment about the lack of standards around these data. And right now, everyone is trying to think about how they can incorporate social determinants of health in their analyses, and how we're going to include these in our AI technologies, machine learning. And so what we're doing is we're looking at, certainly in the digital age, we're looking at historical data and seeing what can we extract from these for social determinants of health. And really those data are very biased in how that information is recorded, how it was captured. And so this is introducing problems when we're using sort of our machine learning and AI technologies in training our data on biased information on social determinants of health. So the ability to set standards and really provide the fundamental resources to understand what types of information do we want to collect, what are the standards for how we want to collect and report that data, and what's the minimum information that needs to go into these healthcare data sets regarding social determinants of health, I think is a very big priority that AHRQ should have some stake in, and be able to push that forward in a very systematic way.
So noted.
Yeah, very well said. I just wanted to put another topic out there, perhaps for further discussion, and something that I think naturally flows from your focus on the increasingly digital world we live in, and that is also a burning platform that I think is where the puck is going in terms of health systems continuously having to wrestle with how are they going to be able to work into systems the emergence and rapid emergence of AI, machine learning, driven decision support, and those kinds of tools. There is an immense, as we discussed somewhat at dinner, there's an immense amount of investment and activity ongoing in this space. Even as we have our sort of broader data science agenda generally across the agencies, the way we need to think about these kinds of applications at the intersection of patients and health systems and how they actually are going to affect healthcare moving forward, I think requires AHRQ to have a key role in this, and I think it fits very well within your agenda. So I would just put that there as something that we should discuss further, because Right now, again, it is something of the Wild West. There's, again, billions of dollars being invested in this space, but very little in the way of evidence in terms of what to do.
I think so this bears further conversation.
So thank you, everybody. I just made a few observations based on what I was hearing. I tend to do a little synthesis after every round of discussion. So Gopal, if you don't mind. As I said, I really like that idea of care is what AHRQ is interested in. And I don't want to be too academic about the taxonomy, but I think we need to explain what we mean by care. So when we start getting into social determinants, and then I heard people starting to talk about public health, and you said CDC does public health, we do care. So if this is holistic care for the whole person wherever they are, not the 5% of healthcare that accounts for health, but a bigger vision, I think you need to be really clear about that, because that establishes guardrails for your pitch. And for the main thing I would like you to think about is, do you have the competencies you have, or do you have to redefine the competencies you need, depending on the vision of what you mean by care? I have the same feeling about the data analytics. There's so far exploration and a little lack of precision about what's meant, and we know that these new approaches, that not so new anymore, data analytics, machine learning, neural networks, and so forth, are going to be important. We have AHRQ T32 fellows who come in now wanting a master's degree in artificial intelligence, not in health services, MPH type thing. What are the guardrails for AHRQ around that? Is this something you partner, or do you, I don't believe the competencies exist right now in AHRQ to be players in machine learning and AI. Maybe they do, and I just don't know it. But if that's, I would, again, establish the guardrails, and because it'll define what you ask for and who you bring on staff. And then finally, the data platforms really are fantastic, and data analytics is really important. I would ask, in service of what for AHRQ? I know what it's in service for the country, but for your agenda, what is it in service? So that would immediately say to me, well, data analytics will show gaps, it will show need, it will show where we're learning something or whatever. That brings you into the field of implementation science. And is AHRQ an implementation science engine? Is that what's going to be funded and emphasized so you can actually close those gaps? Or is that somebody else's job? And with NIH spending, I think, more money on implementation than AHRQ does, what does that mean for the future, and who's going to do that? So those are just things I heard, a little edgy perhaps comment, but I think that really being clear for the boundaries around data and around care is going to be really important going forward.
Thank you, Don. And again, this will require help we can get from NAC members as well as other partners to drill down a little bit more and define some of these, further define the strategies we are talking about. So thank you.
And the chair forgot to approve the minutes from the April meeting, so we need to approve the minutes. And if anybody who was involved in that meeting is here and has any amendments or comments, please indicate. Seeing no tents rising, may I have a motion, please, to approve the minutes? Thank you, Peter and Beth. Anybody want a second? Okay, Jerry, you seconded. And so all in favor of approving the minutes, please say aye. Okay, and anyone who's a nay? That's wonderful. The minutes are so approved, and we can do our break. Please, if you could come back in 10 minutes. We've been very eloquent, but we're really behind. So 10-minute break. Thank you.